Dear colleagues, it is a great pleasure for me to be part of this World Congress of Anaesthesiologists, and I would like to warmly thank the scientific committee for having invited me to give this talk on hypnotic opioid interactions during anesthesia. I have no relevant conflicts of interest to disclose relative to this talk, which will be organized as follows. We will first define those interactions, then envisaging their consequences, how to assess them before finishing with some practical considerations and take-home messages. Let's start with the definition of those interactions. General anesthesia is not always the absence of any sensation, but rather a clever blend of several medications that we administer to our patients to allow them tolerating painful, stressful, or unpleasant interventions. Administration of those medications leads to several pharmacodynamic effects which are modulated according to the needs. They include mainly cognitive effects, and notably an alteration of consciousness, but also anti-nociceptive effects to control for the consequences of noxious stimulation, as well as muscle relaxation to ensure immobility. But this cocktail of medications also leads to unwanted side effects, like, for example, episodes of low blood pressure. Hence, anesthetic medications may interact in several ways, as nicely described in this paper by Vandenberg and colleagues, regarding their kinetics in the body, that is, their absorption, distribution, metabolism, and elimination, and this might have consequences on their pharmacodynamic effects. Pharmacodynamic interactions can be additive, when the effect of a drug simply adds to the effect of another drug. They can be supra-additive or synergistic, when the resulting effect is bigger than the simple addition of each individual effect, or can be antagonistic, when the effect of a drug inhibits the effect of another one. Those interactions may concern not only the desired clinical effects, but also the unwanted side effects. This introduces high complexity in clinical practice, because influencing the dose concentration effect relationship for each considered effect or side effect and for each added medication. Complexity is even more aggravated by the fact that interactions are also influenced by individual factors like age, gender, genetic background, or eventual comorbidities. Interactions are also influenced by several other intervening factors, like the varying aspect of surgical stimulation intensity, the concomitant use of non-anesthetic medications, the administration mode of our drugs, and so on. This makes predictions regarding a given effect at a given concentration for a given patient very uneasy and sometimes almost impossible. If we now come to hypnotic opioid interactions, the main effects of concern for us are the alteration of consciousness and anti-nociception. Hemodynamic effects and respiratory effects are also of concern, but we will leave them apart for today, as well as muscle rigidity, for which opioids and hypnotics are usually antagonistic. Let's take a relatively simple example, driven from the reference paper by Bouillon and colleagues. Let's imagine a propofol remifentanil TCI anesthesia with bispectral index monitoring. On this graph, you can see the isoballs of 50% probability of response to laryngoscopy or to command. In scenario 1, the patient receives high remifentanil concentration and low propofol. The BIS value is 40, and in that case, the probability of response to laryngoscopy or to command is below 50%. In scenario 2, the BIS is also 40, but here the patient receives high propofol and low remifentanil, and in that case, the probability of response to stimulation is higher than 50%. Hence, for the same BIS value, the clinical situation can be radically different. If we do not take account of interactions in our clinical practice, we may experience difficulties in providing adequate anesthesia to our patients, particularly at moments of changes in anesthetic agent concentrations or at moments of changes in the intensity of noxious stimulation. And inadequate anesthesia has consequences. During the procedure, we constantly oscillate somewhere on this dose or response surface. We might be too deep, too light, or just be perfect, but with side effects. Too deep anesthesia is associated with poorer outcome postoperatively because it is associated with increased mortality and increased morbidity, although no evident causal relationship has been demonstrated. Opioid overdose can also lead to hypersensitization phenomena, immunity depression, and the development of chronic pain. And too deep anesthesia also leads more frequently to side effects like hemodynamic events. Too light anesthesia may be associated to more frequent movements of the patients, unexpected awareness episodes with or without explicit recall, as shown here in this video, in a patient immediately after laryngoscopy. It can be also associated to hemodynamic events and increased stress response to surgery. Given all those potentially deleterious consequences of inadequate anesthesia, we have to find means to assess interactions intraoperatively. The first tool that is available and probably the oldest one is the concept of MAC or EC50 or 90. Those MAC or EC are defined for precise event and a precise response. They are sometimes adjusted on our monitors according to the use of other agents like nitrous oxide or individual factors like age, but not always. And nevertheless, they do not take account of all the intervening factors I mentioned before. In addition, they are defined according to untitled concentration, and they do not take account of the lung-brain equilibration time. The flow eye machine is an exception in this respect, providing in real time an estimate of the lung-brain concentration difference. More sophisticated tool can be of great help. They are based on pharmacodynamic modeling, and an example is the SMART pilot. It displays interaction plots where you can see surfaces corresponding to MAC wake, MAC incision 50, and MAC incision 90. Those surfaces are calculated according to the type of anesthetic agents used and their combinations. It also displays the hemodynamic parameters, the bispectral index, the noxious stimulation response index, and the time course of drug concentrations. The noxious stimulation response index is linked to the probability of response to laryngoscopy and also takes account of interactions between medications. But the SMITE pilot is not the only pharmacodynamic tool available. Another one is the navigator that can be of great help. Another mean to assess interactions can be to measure effects, but we all know the limitations of those depths of anesthesia monitors, either for the hypnotic component or the antinociceptive component. They are influenced by several confounding factors, and the prediction at an individual level with them is very uneasy. So, practically speaking, what can we do? I think we have first to gather as much information as possible on the patient status using concentration estimates of our anesthetic agents, using the pharmacodynamic modeling tools I've shown you, and using some of the available indexes of the depth of anesthesia. A step further can be the use of closed-loop systems, which react more rapidly than human beings and provide more stability. Another step further can be the development of decision helping systems that can facilitate the integration of all the available information. But on top of this, the anesthesiologist at the bedside of the patient, with his own or her own clinical experience and expertise, and able to anticipate specific surgical events, must remain the captain. I thank you for your attention.